practical examination is next Wednesday. It'll run from 1 to 5. The class will be split in half. And I'll let you know that no later than Monday, but probably later this afternoon. Do not show up at where you're not scheduled, okay? So you're going to enter the laboratory. There will be 40 stations set up in the laboratory. There will be cards by those stations. You will all basically start at a different station. It's what's sometimes referred to as a bell ringer exam. So as the buzzer goes off, you'll move to the next station. You will have 70 seconds per station. Okay? If you think that's not enough time, it's actually a lot of time. It's not enough time if you don't know what you're looking at. Okay? Remember, that's what I told you. The first thing to know is what you're looking at. All right, in relationship to that, the laboratory will close Tuesday at noon. All of the skulls that have been checked out have to be back in the lab by Tuesday at noon. Okay. About 50% of the lab stations will be related to some type of bone structure, either in relationship to probably something what attaches here, or what goes through this opening, or things in relationship to, you know, if it's a nerve going through an opening, what type of components does it possess, and things like that, okay? That, you walk in the room, we will give you a sheet to go with a clipboard, which will be at the station, okay? There is no going back at the end of the lab to go back to any previous stations, okay? You will have about 2 minutes at the end to just go over your papers. There will be some rest stops that won't be on the sheet of paper, but are there basically so, you know, give you some catch-up. In other words, look at your paper and make sure you put things. My suggestion to you is not, there will be, you know, basically 40 or so blanks on the sheet of paper. Do not leave a blank. Put something there. Because it's kind of hard to think about what you maybe you weren't sure of something and you didn't want to put anything down, but it's hard to go back and then say, oh, I don't remember what that was, or something like that. A lot of times, as you move from station to station, you'll find that there is a station that is similar to that area that you looked at, and that kind of gives you a tip to what it was you thought. You know, it gives you the differentiation, okay, in relationship to that. The written examination is on Tuesday, the 30th, okay? It was switched with facial growth, okay? And that will go from 1 until 4, okay? Okay.
How many questions?
The laboratory examination is 40 stations, 40 points. The written examination has, I think at this point, it has 52 multiple choice in questions that are worth a half a point apiece. So that's 26 points. There's also on that, I think right now, 25 are classified as fill in the blank questions, okay? Some of these questions have images attached to them, okay? Some of these questions have images attached to them. The other thing that you will get is you will get a short test booklet with things that you will have to write in or fill in that test booklet, okay? So that is something that you will turn in. Everything else is unexemplified, okay? Everything else is unexemplified. So it's basically a total of 60 points, okay? And once again, out of the 100 points, you had the opportunity to pick up 10 points on your formative exams, okay? That doesn't mean that we have 110 points. It means we have 100 points, and if you have the luxury of that 10 points, don't blow it, okay? So that's how the course will be scored, okay? I'm trying to think, is there anything else? Yes.
We have to pass both exams individually, correct?
You have to get 70% of 100 points.
Oh, so. Okay.
That's it, you got it. That's it, you got it, okay? But if you don't, then you will have to repeat. If the problem is the written exam, you will have to remediate the written exam. If the problem is the laboratory exam, you're going to have to come to class this summer. Yes.
I'm confused. For the written portion, you said 52 multiple choice and there was 25 fill in blank, but it's graded out of 60.
The multiple choice are half point.
Multiple choice or half point.
Oh, okay.
Okay, so that's 26 points.
Yep.
Yes.
If the 70% is what you need overall, then what do you mean by if you like fail the practical or the didactic, you have to remediate it?
You're gonna have to, if you're on campus, okay, you're going to be able to possibly start your remediation sooner. I mean, if I was you sitting here, I would not be thinking about that you're gonna remediate this class. That's a bad point to start. If you, in relationship to the laboratory, we will have a turnover of cadavers, okay? And new cadavers will not be coming into that lab until late June, early July. So we can't remediate your laboratory, we can't help you with relearning the laboratory stuff until that period of time. So if it's the lab that you mess up on, that created the 70%, the below 70% issue, then you're gonna have to come in the summer. And you're gonna have to basically sit in on the graduate head and neck course, which starts second week of July. Yes.
So when you're talking about the fill in the blank questions, is that what's gonna be in the short test booklet, or is that unexemplified?
That's an example.
That's okay. So what did you say was on the short test booklet?
I didn't say.
Is that
There's a couple questions. Okay, so now given that information, distribution of questions on the written examination are pretty much, obviously I have the bulk of questions. Dr. Wolf also has questions in relationship to it all on the D, I think he mentioned the D-face, and then pharynx area, oral pharynx, laryngophonics. Okay, so she's contributing questions on those two areas. Okay, Dr. Syed has contributed some new questions to the, I think there are 3 or 4, okay. Dr. Pinto has given questions about 3 or 4. There are some questions from Tamler, I think they're once again about 3 or 4. Okay, so other than myself, those are the other contributions. Okay. Pretty much covers everything that we've done. Pretty much covers everything that we've done. And some of that should be reiterated in some of these cases that you're doing. Okay. So, I don't expect anybody to fail, okay? Because I know that, first of all, you don't want to, but second of all, it takes a little bit more than not wanting to. And I'm making an assumption that you have done an awful lot of studying over this first year of your dental education, and that you will have enough understanding to be able to answer the questions. Okay. Nothing that we haven't covered. Yes?
Did Dr. Frideau give
Yes,
you
I'm sorry,
something?
Dr. Frideau was, I think 3 questions from Dr. Maybe 4. besides who gave me the questions, do you have anything in relation to not understanding? Yes.
Our people had one question today about, like, the dangerous space, how, like, a lot of textbooks are saying it's actually the prefigurable space, but we've in class talked about it being the, retropharyngeal, thank you.
Okay, it's the same.
Retropharyngeal?
It's prevertebral fascia is the posterior.
Yeah.
Okay, retropharyngeal space, there are potentially two ways to look at it. It's anything that is in front of the prevertebral fascia, which basically is made up of longus colli, longus captus, and some of the muscles that come along the back of the vertebral column, okay? Now, in front of that, there can be two fascial layers. One could be alar fascia, which is a little bit lower in position because it's coming really close to where the common carotid gives off internal and external carotid, okay? And I showed you, if you were in the lab, that one head that is inverted with where you can actually see the alar fascia. But in front of that is the deep fascia that is part of the middle cervical fascia that is on the inside surface of the pharyngeal constrictor muscles. Okay? So on the inside surface, superior pharyngeal constrictor, middle pharyngeal constrictor, inferior pharyngeal constrictor. So anything that lies between those layers, okay, can enter into the retropharyngeal space. Okay. So even though there's potential for this intermediate alar layer to be in there, basically the most anterior aspect of that, sometimes it's called a buccopharyngeal curtain. Dentists use that terminology sometimes, or it is the visceral layer of middle cervical fascia. Okay. Yes.
In a textbook and some online resources, I found that like sometimes alar fascia can be considered a derivation from prevertebral. Can you like clarify that, or whether or not it is? from-
Alar fascia is actually alar fascias are actually part of all three letters.
All three? Okay.
Okay, ala means wing. And I think I showed you both on the drawing when we were looking at it, and recently in the laboratory, I showed you that there are wings from each fascia layer that come to the carotid sheath, okay? And then between the two carotid sheaths, that fascia can cross to the opposite side. Okay. So the alar fascias that help to form the carotid sheath itself is a fascia that comes off the surface of the vessels that are in it, okay, the structures that are in it. But also that those wings, definitely there's a wing from the prevertebral fascia, okay, but there are also wings from the investing layer, and there's wings from the middle fascia.
So it's more of those fascias connecting to the
Right,
carotid
right.
sheath, not
Each
from
one of
the-
those wings helps to form the carotid sheath, and the alar fascia, though, can cross from side to side.
Okay. Thank you.
If you want to read a more detailed explanation, I've got two treatises, each 150 pages each. They were written in the 1950s. So if you're really that interested in fascia, just let me know.
Thank you.
Yes.
As far as like the lab portion, how are you able to distinguish the phrenic part, a nerve versus the vagus? I know that the phrenic runs on top of the anterior scalene, but
That's one way.
where's like how can we tell where the vagus is?
Where would the vagus be in relationship to the frontal?
Oh, okay.
It would be more medial too.
Supermedial.
Carotid sheath is more medial than the scalens. Okay.
Thank you.
Okay. Yes.
Are vertebral arteries and veins going through the transverse foramen?
Yes.
Of the vertebrae?
But the artery only goes through the upper six.
Okay.
The vein goes down through all seven vertebral foramen and the transverse processes.
Okay.
The artery only goes through the upper six.
Another question following up with Anna, isn't it the recurrent phalangeal nerve the one that's medial to the phrenic nerve? Or just the veins? Because I saw an image that.
No, yeah, you're right. because the airway is also more medial. Okay, the airway is actually more medial than the carotid sheath, right? Okay. I mean, so if you went from phrenic nerve is running over into your scalene, and sometimes you can actually see it coming from the brachial plexus, the first rami, C5, because it's C3, 4, 5, keeps the person alive, okay? And then as you go out medially, okay, you have the carotid sheath, and inside the carotid sheath is the vagus nerve, and then immediately adjacent to that is going to be the airway and the food tube, and running between the esophagus and the trachea coming up to the larynx. Usually in that area, it usually comes in deep to the thyroid gland, and it enters usually between a gap between the back of the cricoid cartilage and the thyroid cartilage. Okay, that's the phrenic. I'm sorry, that's the recurrent laryngeal. Okay, so it goes phrenic nerve, vagus nerve, recurrent laryngeal. What about out from the carotid sheath? What's the most superficial nerve associated with the carotid sheath? Ansa cervicalis. Then vagus nerve. What's the deepest nerve? Sympathetic trunk.
To follow along with that
Sympathetic
for
trunk.
recurrent laryngeal and then sympathetic trunk. To follow up with that.
Oh, where it will be in relationship to sympathetic trunk.
Yeah, it's, as far, sorry, it's,
Okay, the sympathetic trunk is going to be right against the lateral side of the vertebral bodies. Okay, so the vertebral bodies are deep to and medial to the carotid sheath.
thank you.
Something got messed up with the scheduling yesterday, because I was there from 2:30 to about 4:45. Okay? And one of the things I was going to try and focus on, but I'll try and focus on it Monday, which is the last time I'll be able to meet with you before the meetings. By the way, if you get a chance, you might want to pick up some, we've only got, I think, 40 of the disposable gowns left, so the order hasn't come in yet, so that may be here by Monday, but if you're gonna go in there this weekend, you know, that, or if you wanna borrow one of the lab coats that's in my locker. Some of them look okay, so,
Can we go right now?
huh?
Can we go into the lab right now? And do what you were gonna do yesterday?
No, not with me.
Well,
I have also, I sent out requests to all of the TAs, I told them I was gonna be in the lab, okay? I suggested to them that they try and schedule time with you, or you schedule time with them so that they can help you in the laboratory, okay? So hopefully they will do that. And they've got, remember, they've got finals coming up too, so. But what I was going to focus in on is thinking about how you approach an area, how you approach a station in practice. So I've told this to many of you. You look at a region and you find something in that region that you absolutely know what it is, okay? And then you now know everything that's in front of it, everything that's lateral to it, medial to it, superficial to it, and deep to it. But using a reference point, that is what will help you know what you're looking at within the confines of the head and neck. Okay? So, for example, if you see the face and you see the parotid duct coming from the parotid gland, you would say, okay, I know this is the parotid duct. What muscle does the parotid duct go through? Okay, what fibers of the facial nerve typically run above the parotid duct? Zygomatic, okay. What below it? What fibers below the parotid duct? Above. Okay, then below that, running to the mandible, marginal mandibular is just a split of the mandible, okay? I'm not gonna mark you off, but I have that view and you put down, marginal mandibular, you're not gonna get that. And then below that is going into the platysma muscle. So if there's no platysma muscle, it's difficult to see the cervical range. But if the platysma muscle is there, you will see the cervical branch coming down and going under it. Okay, so let's take another region. Let's take the neck. Okay. What structure do you think you can, and we talked about this actually relationship many times, think about in the neck that is something that you should be able to identify.
Anterior is
Sternocleidomastoid, okay? What's on the outside surface of the sternocleidomastoid? Okay, anything else? Superficial cervical plexus. What typically runs parallel to the external jugular? Greater auricular, okay? Now you pull the sternocleidomastoid back. What would you see going into the sternocleidomastoid underneath it? Spinal accessory, probably right near the border of the mandible. Okay. What structures would you now see from superficial to deep underneath the sternocleidomastoid? Ansa cervicalis. What's in the carotid sheath? Jugular vein. What would you see behind the carotid sheath?
Sympathetic.
Okay. Okay, now you should be able to recognize the digastric muscle. Okay. So the posterior belly is a little bit harder to see because it's tucked in under the lower border of the mandible. What muscle would run parallel to it on the inside? Deep to it. Stylohyoid. Runs parallel to the posterior belly. That's what the tendon of the digastric goes through at the hyoid bone. What structures would you see below the posterior belly? Inferior. Hypoglossal nerve. What would you also possibly see, whether the muscle separating it or not from the artery? What would the artery that would be a little bit deeper be? Deep to the hypoglossal nerve. That's a constant relationship. What is that? Lingual artery. Okay, lingual artery. What if you saw a little twig, a fiber coming off, coming below the hypoglossal nerve and going to the thyrohyoid muscle? What would that branch be? What would that nerve be? C1. Okay, going to the thyrohyoid. What's your key structure in the oral cavity? The floor of the mouth, adjacent to the tongue. What's the key structure? The lingual nerve. Okay. What does the lingual nerve pass under? Submandibular duct. What's the submandibular duct connected to? I know that's a tough question. Submandibular gland, right? Okay. Now, if you can see this, if you can see that relationship and you know the lingual nerve, what might you see underneath the lingual, on the inferior side of the lingual nerve, interconnected to the submandibular gland? What would you see? Submandibular ganglion. What would you see running over the hyoglossus muscle on the posterior lateral surface of the tongue? Hypoglossal nerve. What would you see running over the styloglossus muscle on the posterior aspect of the tongue? Glossopharyngeal. Okay. Glossopharyngeal, it's definitely the smallest one. But I mean, it typically lies running over the surface of the styloglossus muscles, attaches to the posterior lateral corner of the tongue, actually just behind the hyoglossus. Okay. Okay, so that's the kind of thing you have to pick up on to the lab, okay?
Mhm.
For lecture, you just have to listen, you have to go, just remember everything I told you. In particular, in relationship, for example, the relationship of the lingual nerve, and, lingual artery and the hypoglossal nerve. I mean, remember, there's the hypoglossal muscle runs between them, okay? Or remember, when we looked at the intertemporal fossa, we had the we had the branches of E3, which are the most obvious branches of the trigeminal in the infratemporal fossa. We had the maxillary artery in there, okay? So you should be able to know those. You should be able to tell me what nerve component is in each cranial nerve and each cranial nerve branch. Okay. If I tagged, for example, the lingual nerve and asked you what type of nerve components are in this nerve trunk, GSA, SVA, and GVE, okay? Which ones are facial? GVE and SVA. Which one is temporal? I mean, is trigeminal. GSA. Remember, trigeminal nerve is the primary general sensory input in the face, in the pharynx, okay, coming back into the nervous system, okay? That's GSA.
So it doesn't have SVE?
Not in lingual, okay? Which one of the branches of the mandibular division carries SVE?
Inferior.
Okay, inferior alveolar for one, carrying the mylohyoid, but also the mandibular trunk gives off the branches deep to muscles of mastication. Okay. That's the only trigeminal branch, trigeminal division, so we're correct, that has SVE. Is there SVE in the maxillary division? Is there SVE in the mandibular division? I'm sorry, ophthalmic division? Okay. However, what did those two entities carry?
GSA.
They carry GSA, but what can they carry as a conduit for other cranial nerves?
Yeah.
They can carry GVE either in relationship to the nasociliary branch of the ophthalmic receiving these sympathetic fibers along ciliaries innervating the dilator of the pupil of the eye, or in relationship to the maxillary division that is carrying all of the secretomotor branches of the facial nerve to the same surfaces that they receive sensory information from, okay? Including this little crazy zygomatic branch, which gives off the postganglionic fibers to the lacrimal gland. And that actually interconnects to its cousin, so to speak, the ophthalmic division, to carry those fibers into the lacrimal gland. Okay. So that's what you have to think about. Okay. To be honest with you, I mean, the next time I see, well, I guess I will see you first semester next year, like semester. But if when you go into clinic, these are the things you have to, as a patient presents to you, you have to think about what they're saying to you. What kind of, are they having issues? What kind of issues are they having? Things like that. Loss of taste sensation maybe, or they have a dry mouth. Why do they have a dry mouth? Is it the medications they're taking, or is it relationship to some type of problem with the innervation from autonomic and particularly parasympathetic supply to mucosal glands and salivary glands? So what other questions do you have? Yes?
In terms of what passes through the foramen or valley, Dr. Wolf taught us like the O-Valley acronym to like remember it, or the mnemonic to remember it. But is the otic ganglion actually in the foraminal valley?
Yes,
It is.
but it's deep to the mandibular division as it's passing through it. And that's what makes it so difficult to see. I mean, you'd have to really butcher up infratemporal flush and actually go and see that. Okay. You're not gonna see another ganglion, but you should know what it's about. What is it about? What is the otic ganglion associated with? So what kind of, is it autonomic? Is the otic ganglion autonomic? No. No. Parasympathetic. What's the parasympathetic nerve branches that it's associated? Which cranial nerve? 9. Okay. Where did those 5 branches come from? Which branch of 9?
Go ahead, Joseph.
They come from the tympanic branch, which enters the inferior tympanic canalicculus, passes through the middle ear chamber, and provides some sensation to the mucosa there through what's called the tympanic plexus, leaves the middle ear chamber through this tiny slit, which up until maybe 10 years ago had no name, which is lateral to the hiatus of the greater petrosal or facial nerve, and then goes down in the synapses in the otic ganglion, and that's called the lesser petrosal branch. Yes.
Is there GSA in the motor portion of the ansa cervicalis, or just
Yes,
GSA?
yes.
So it's
As
GSA.
I mentioned
and
to you,
GSA.
whether it's mentioned or not in anatomy textbooks, there is proprioceptive feedback at least coming back from skeletal muscles.
Okay.
And remember, those muscles, those infrahyoid muscles, those come from psoas. They don't come from branchial arches.
Mhm.
Laryngeal muscles, however, come from branchial arches.
So the motor portion is GSA and SVE? Oh,
GSE.
GSE. Oh.
If they come from psoas, they're GSA.
And then the superficial portion is just GSA?
Yes, GSA. Yes.
With the tympanic branch of the glossopharyngeal and the relationship with the otic ganglion, can you clarify what you mean by like it turns into the lesser petrosal branch?
Because first, it goes through the middle ear chamber. But first it goes into the middle ear chamber and gives off these GSA fibers
Yeah.
with pain sensation in the middle ear. Then when it leaves, that's when it becomes lesser petrosal.
Okay.
For cervical plexus, do we need to know the roots?
For which,
Cervical plexus, brachio.
you need to know the rami, which most authors call roots, and you need to know the trunks. C5, C6, C7, T8, C8, and T1 are the rami. Okay? C5, C6 come together and form the upper trunk. C7 continues as a rami, continues as a trunk. C8 and T1 come together as a lower trunk. We'll talk about it more when we talk about musculoskeletal medicine. Yes.
Can you also call it the superior, middle, and inferior trunk?
Yeah.
Okay.
As I was cleaning out my office this week, and I'm kind of amazed at myself and I've been able to do this. I have some stuff that, towards anatomy type things and things like that, and I found the article that was in the newspaper at the time of Frank Netter's death, talking about Frank Netter. You want to see that? You're welcome to come and see it.
Good.
Because you don't need to body the science.
You don't need to bother anything about. all be able to pass this examination. Shouldn't be any problems in passing this examination. I understand the difficulty of the lab stuff. What did I tell you about the lab stuff? How do you learn the lab stuff?
Go in the
Go
lab.
into the lab. Go into the lab. Actually, while I was there by myself yesterday, I would find some things in some of the cadavers, so you should go back and look at some of that, Okay. Including some things we had talked about just recently.
Can you explain, you were talking about the hypoglossal going along the digastric?
The hypoglossal nerve, okay, remember we had these triangles?
Yeah.
And what separated the anterior triangles from the posterior
The
triangles?
ceratomaster.
Okay, so in front of the ceratomaster we have 4 anterior triangles. Okay, and there is one that's directly under the mandible that is actually two of the sides are created by the digastric, posterior and the anterior belt. And the third border is the lower border of the mandible, okay? Just below that, and a little bit more posterior, is a triangle. It's called the major vascular triangle or the carotid triangle. Okay. Now, if you remember, 9, 10, and 11 leave from at least the standpoint of the motor innervation, they leave the jugular foramen and they come down together. Okay. Hypoglossal nerve is right behind them, and that comes down too. So where glossopharyngeal and vagus may give off branches into the oral cavity, in particular the tongue, the hypoglossal nerve comes down to the carotid triangle, and then it loops up. And where it loops up, as it's coming in, it will go from the major vascular triangle to the mandibular to the digastric or submandibular triangle, and it'll go through there. So where's it going under? It's going under the posterior portion of that triangular side. It's running underneath the digastric. So that relationship is constant. I mean, so if you cite something and I have a tag and it's coming up under digastric, that's what it is. Okay, that's what it is. Yes?
So the relationship of the hypoglossal while it's in the carotid triangle, what is it like superior to? Is it still?
It's just anterior, it's just a little bit, I shouldn't say anterior, just a little bit posterior to where the spinal accessory nerve is going into the underside of the sternocleidomastoid. Okay. What kind of nerve components in the hypoglossal nerve? GSC and SVA. Remember, other than one muscle, 3 of the 4 glossal muscles are coming from somites. Okay. What's the one that doesn't? Palaeoglossus. Palaeoglossus. Yes.
Sorry, for the lab practical, do we have time in the very beginning to write a few notes?
I will give you an opportunity.
Okay, thank you.
Your first 70 seconds.
Practice that chart.
7, that's it. What? Yeah, write down. Write it down on the back, not on the front. Okay, and please write as clearly as you possibly can in those blanks so I can read what you say. I know some of you write, you know, you have very nice, succinct handwriting that you write in 8 font. Try and make it a little bit larger. Printing is actually yes.
Can you explain how Stationery gets the GSA fibers?
How it gets GSA fibers?
How it has GSA components?
Because it innervates skeletal muscles That's where the predominant majority of the GSA. But there's some authors that feel that the facial nerve actually has GBA coming into it too. And nobody has really explained that where the receptors are. They say the receptors are in close proximity to the external acoustic BAs, okay? But nobody's ever said what kind of receptors are they. Okay, to be a GBA receptor, you have to monitor things like stretch in blood vessels, or chemoreception, or some type of entity that is taking place within a visceral tubular entity.
You mentioned something about spindles.
Muscle spindles are the primary proprioceptive mechanism in skeletal muscle that detect stretch. Okay. The other organ associated with skeletal muscle is called the Golgi tendon. And what that's monitoring is the force of contraction of the ends of the muscle. It's actually a kind of a protective mechanism. We'll talk about that in next semester in musculoskeletal. So those are the two primary proprioceptive mechanisms. However, there are entities, for example, there are stretch receptors associated with periodontal ligaments, but they're considered to be GSA, not GBA, okay? So I would never ask you at this point in time to make any kind of correlation about facial nerve and GBA. The GSA, yes, okay? Now, the problem is, and we'll talk about this in neuro, are the cell bodies, okay? This is a sensory entity. The majority of sensory entities are what we call a pseudounipolar neuron. The receptor is taking information to the cell body that sits in the ganglion. Okay. In the spinal cord, it's easy. It's basically posterior root ganglion. When you get to cranial nerves, it gets a little bit more complicated because the ganglion are kind of hidden somewhere within the confines of the skull. For example, the trigeminal ganglion is in the middle cranial fossa. Okay. The genicular ganglion is inside the inner ear. Now, for the facial nerve, the genicular ganglion is believed to take some of these first-order cells for proprioception, but also for taste sensation. Okay. But the second-order cell is in a nucleus in the brainstem that's associated with the trigeminal. And there's some authors that believe that other entities, such as extraocular muscles, or possibly even facial nerves, sense its proprioceptive information back to the mesencephalic nucleus and kind of skips the ganglion. Obviously, these are hard things to find, you know, starting with embryonic life and then going into an organism and trying to find tiny little rootlets and trace them all the way back. But Julie, that's what they're about. That's why there's GSA. That's why there's GSA in oculomotor. That's why there's GSA in trochlear. That's why there's GSA in abducens. Okay. And that, where you see all of that, you see it in neurotext.
Figured it out.
You're all happy now, no? You're going to be successful on this examination. Yes, no?
What about origins and insertions of facial muscles?
You don't need to know origins, insertions, and facial muscles. You need to know origins, insertions, masticatory muscles, and just about anything else. Okay? Masticatory, you know, it's not by the mastoid, that's kind of a giveaway. You know, things like that, infrahyoid muscles. Okay? Huh? What else?
So,
That's pretty much, pretty much what it is.
Infrahyoid muscles and SCN are originated insertion.
Along with masticatory muscles. You should know the origins, absolutely you should know the origins.
with the insertions of the the suprahyoid muscles, do we just need to know
You
that
should
they go to the
those inserts. You
hyoid,
should
or
know
do
those,
we?
like digastric mylohyoid, stylohyoid, hyoglossus, you should know those organs and insertions.
Do we need to know that they the particular area and the type of connective tissue that it goes the hyoid to, or just that it goes the hyoid?
In some textbooks it says greater horn, lesser horn, and others it just says.
Yeah, no, I know, I mean, just know that it attaches to the hyoid bone. Anything else on your minds?
Okay. The internal carotid artery passes through the carotid canal, but also I read something where it passes through the brachioplexum.
Internal carotid,
It's the branch of it.
is this external? External and common, what are you talking about? Which carotid?
The
External carotid?
I was talking about
pharyngeal branch of the
pharyngeal branch, what's going on?
the external.
There's a branch of the external that goes to the serum that actually is ascending pharyngeal. There are some people, I think, that say that there can be a branch of internal that goes through the okay?
Is the ascending pharyngeal a branch off of the maxillary, or it's a direct branch off of the external?
The ascending pharyngeal comes in just deep to where the facial nerve leaves and goes more superficial. The ascending pharyngeal creeps up the lateral wall of the pharynx and goes through the base of the skull to the serum. You're not going to see it. It's a real thing, just like costocervical trunk is very thin. But there are some, in this particular group of cadavers, there's some nice thyrocervical trunks and vertebral arteries that are quite visible.
Wait, now I'm a little confused. Okay, so if the ascending pharyngeal branch goes to the serum, but doesn't that also go to the hypoglossal and then
Give me a reference for that. I mean, there could be some authors that have described this for whatever reason going through some. I mean, there's actually one of the lab atlases that was created by Grant years ago. He used to look at a lot of anomalous type things. So he might have seen it in one of his dissections and made note of it, and then his followers, passed that on from generation to generation. But as far as we know, from the standpoint of most common, it's going to go through the formula cell. The ascending pharyngeal. Don't worry about the others. Just like there's believed to be a branch of the occipital artery that goes through jugular foramen to give rise to a posterior meningeal branch. Okay? But sometimes that may come through formula.
So I was looking at one of the cadavers, and I thought it seemed to be the first branch off the subclavian, so I thought it was the vertebral, but then the tutor said that it was the, what is it, thyrocervical?
Thyrocervical is going to be a little bit more,
Right,
more
lateral.
yeah.
But, so is there any other kind of things that we can use to guide that would come in between the vertebral
If
and the
on
thyrocervical?
the two cadavers that I know specifically, because I looked at them again yesterday, that the thyrocervical trunks are quite obvious, and they're right there at just at the border of the anteroscapula. And then medial to the anterior scalene, that's really the subclavian, okay? And so if you go a little bit deeper, you will see, you may even see the internal mammary, the internal thoracic coming down, and you'll see this continuation of the subclavian into that sixth cervical vertebrae area. Okay, you can see the vertebra. So I think it's a good sized vessel.
So the vertebral's deep to the anterior scalene?
It is deep to it, but it's also medial to it.
Right.
It's in that space, it's in that subclavian triangle.
So we might not see it as clearly at all.
I will tell you this, I try my darndest to get the sections as close to an atlas as I possibly can. Okay? So if you haven't seen it in the lab or you haven't seen it in an atlas, I mean, it's kind of on your back. Okay? As I said to you before, almost everything that we talk about here can be seen in the laboratory. Anything else? Any more cards, Judy?
Material, I think it's figured out.
Okay, so, like, I will be in the lab from 3 to 5 on Monday, okay? Like I say, if you're going over there, you might wanna, because I do not, if you're going over this weekend, know that there's just 40 disposable gowns left, and there were no masks, there were hats. So, but there should be more on, for the Monday night. But they have them at the dispensary. So you want to grab one or two before you go over there this weekend. Or like I say, you remember lab coats hanging around